Okay, there's a few more people that are logging in as I'm speaking, but I think I'll just get started with reference to the topic for today, which is treating acute pain with laser therapy or photobiomodulation. But today I'm going to reference more laser therapy because it's something that to do this, you kind of need to use a laser. And I'll explain that, one component of it. If you're not familiar with who I am, my name is David Kunashko. I'm a chiropractor and trained acupuncturist. And prior to all that, I was in science, in molecular biology, molecular genetics at University of Toronto. And I've been practicing for longer than I care to add up. But over the last decade, I've been using a lot of laser therapy or photobiomodulation. And it's been extremely helpful in many different ways. And so now, of course, I'm the medical director at BioFlex Laser Therapy, where my main role really is education, and where I speak at conferences and do trainings and do events like today so that people can learn a little bit more about a photobiomodulation laser therapy, how they can help their patients or how they can help themselves at home using this phenomenon of light that induces different positive changes inside the body. It's not pseudoscience anymore. There's certainly more than enough evidence to show that it is doing something more than a placebo. So bearing that in mind, I'll start today's webinar. If you have any questions, let me know in the Q&A box. Type them in as we go along. That's what I'm going to be referencing at the end of today's webinar. So certainly I would appreciate if you can type in those questions. Let me know where you're from, your name. If you're using any equipment, that would be great. And again, I do two types of webinars. One type of webinar is for more our consumer line of devices. So the topics are how to use that equipment at home for treating different conditions. But I also do a type of webinar more geared towards healthcare professionals that are using medical grade equipment, oftentimes BioFlex. And the idea there is to get a little bit more detail given their background and then how they would specifically use our equipment or similar equipment to achieve good clinical results. Anyone can watch any of the webinars. They're complimentary, so don't worry about that. But today's webinar in particular, I had to go into some detail so that we can all understand about acute pain. And that involves a bit of physiology and some understanding of the knowledge. I want to do a bit of review of that as well. Then I'll get into how laser therapy can be helpful for acute pain. And then I'll specifically get into how you would use, especially lasers, in order to achieve some effects on acute pain. And there's two different ways you can approach this, actually. So it's quite interesting. And then I'll have time at the end to do any Q&A that you have. So laser therapy has, in fact, been used for pain management for a long time, like over 3 decades, probably more. We all know that pain is a pretty subjective experience. People can perceive it in different ways. Some people have a high pain threshold, you might say, usually women, and other people have less of a pain threshold. And I can really relate to today's topic because I strained a muscle in my lower lumbar area on the weekend. And, it was spasmodic pain. So, you move in any direction and you're crippled in pain kind of deal. So I, today's webinar is certainly appropriate, definitely a lot better. And I have been using laser therapy in these ways I'm talking about today. So it's always a good reminder that, that it actually works or it can be very helpful. So obviously pain is going to be a warning signal, especially acute pain, to the fact that, you're injured or your patient's injured. And this, of course, triggers a whole pathophysiological series of events that are very well mapped out in the body in a chronological order with respect to the patient perceiving pain. The pain intensity is usually most prevalent in the inflammatory phase as well. So I'm going to talk a bit about nociception and initial onset of acute pain, and then the inflammatory aspect that comes along with that as well, because you're going to be treating these in 2 different ways. And then, of course, it can turn into chronic pain. And I'm not going to talk today really about chronic pain. I may do a separate lecture on chronic pain. Today is focused more on a patient comes in, and this is the worst case scenario. You know, it comes in a lot of pain, and your job is to make them feel better that day. That's what they're paying you money for. That's what they're coming in for. They want relief, right? A lot of pressure on you as a practitioner to help them out. And laser therapy can be one of a great therapeutic tools in your tool set to help achieve that, along with maybe some other things that you do as well. So we know acute pain results from activation of peripheral pain receptors, and these are sort of attached to afferent pain receptors are fibers called A delta and C sensory nerve fibers. So these are called nociceptors. So nociceptive pain essentially is caused by tissue injury. It can be somatic or visceral. Now, today I'm going to really focus on somatic because we're not really going to use this for visceral pain. And if it's visceral pain, which again I can relate to, I passed a kidney stone. I know I'm a wreck. I passed a kidney stone not too long ago. And that was some visceral pain, very different than somatic pain. Not very pleasant either. That I could do nothing about. Just had to let nature take its course there. So anyway, somatic pain receptors, they're obviously located in skin, subcutaneous tissues and fascia, connective tissues, periosteum, joint capsules, that kind of thing, muscle tissue. That's what we're talking about. And typically, that's what patients are coming in for to see you guys about, right? Now, it's a stimulation of these specific receptors, and it's usually going to produce either sharp or dull localized pain. Sometimes it's burning or pricking pain. So it all depends on the source of the pain and the tissues and so forth. Now, these pain fibers will make their way to the spinal cord, especially at the dorsal root ganglia, and then from there they'll synapse in the dorsal horn, and from there they cross over the spinal cord and travel up the lateral columns. They have different names up the spinal cord, and then eventually to the thalamus and the cerebral cortex. So these primary afferent neurons have three functions with respect to the role in nociception. And the first one is transduction. Transduction is essentially detection of the noxious or painful or damaging stimuli. And then there's conduction, which is passage of the sensory input along the peripheral terminals to the spinal cord. So that's conduction. And then transmission is a synaptic transfer from those sensory neurons from the origin into the spinal cord and then up and down your spinal cord into the brain. So this sensory information, essentially, as we know, arises from noxious stimuli, and then it's relayed to all these supraspinal structures, including the thalamus and brainstem that I mentioned earlier. So this is essentially what the pathway, to visualize what it looks like. You have the insult there, and then the A delta and C fibers are irritated, and I'll talk about how they're irritated shortly. They travel to the dorsal horn of the spinal cord, they cross over, and then depending on what fibers they are, they'll go along the spinal thalamic tract or the spinal reticular tract, and then, synapse along the way eventually to the cortex. So when we're dealing with today's topic, which is acute pain, this is adaptive type of pain. So this is typically the body is going to adapt to it and respond to it in different ways. And there's really two types of acute pain you might see. One is nociceptive, sort of direct irritation of the nerves due to tissue trauma or damage, and then an inflammatory process that comes along as well relatively quickly that can also cause acute pain, as opposed to chronic pain, which oftentimes is referred to as maladaptive pain or pathological pain. Examples like neuropathic pain, for example, desensitization of chronic pain, of acute pain into chronic pain. That's a whole different beast, and I'm not going to really focus on that today. Arbitrarily, and you hear this discussed in different ways, usually if pain's lasting more than a few months, it's considered the chronic kind of scenario. There's not really anything that major changes to turn acute into chronic. There's essentially just different states, and certain things happen in the spinal cord level that can trigger this chronic pain. So nociceptive and inflammatory pain, as I just showed you in the diagram earlier, are subtypes of acute or adaptive pain. And as I've mentioned before, that this pain signal can be modulated, and it can both in the segmental and descending pathways by different mediators like endorphins. We've all heard of endorphins and enkephalins. That's one example. Different monoamines like serotonin, norepinephrine. And these can interact, either increase, sustain, or shorten or reduce the perception of and response to pain. As I mentioned earlier, it's A delta and C fibers. So if you sort of want to visualize this, what it looks like, there's several different types of afferent pain or afferent fibers. There's A alpha, A beta. These are more for proprioception or touch, reflexes. That's not really what we're talking about today. We're talking more about A delta or C fibers. A delta is more for fast transmission of pain. So example, if you were to take a pinwheel and they do that sensory test, that's testing for A delta fibers, very quick, sharp pain. Whereas C is unmyelinated, smaller fibers, slower transmission of pain, usually more associated with muscle or ligament tears, kind of itching kind of pain or burning kind of pain. That's what we refer to as C fibers, a little bit slower kind of pain, maybe more achiness kind of pain, but still considered in the acute kind of scenario. So this acute pain, is transferred in different ways and different stimuli. Essentially, this painful sensation is going to persist until the harmful stimulus is taken care of by the body. As I mentioned earlier, the continuing painful sensation is transmitted via the peripheral nervous system by C fibers, which are unmyelinated. It's relatively slow, but C fibers are highly branched as opposed to the delta ones. So because they're branched a lot, the pain that's perceived through C fibers tends to go into neighboring areas as well. So I'll give you an example. If you have like a sprained ankle, you'll feel pain not just where that tissue ligament damage was occurring, but in that whole general ankle area is achy and sore. And that's because of the C fibers emitting pain. So that's a little bit different than having a very specific area, like say like a paper cut, for example, where you feel that sharp pain is very localized. That's usually A delta. Now, there's inflammatory pain. This is a different beast, right? It's associated with tissue damage and infiltration of immune cells. And these immune cells can promote repair, but also cause pain hypersensitivity, so increase in pain until the healing occurs. So our body overreacts to pain, hence why people get a little freaked out when they're in a lot of pain, right? Because they feel like there's something really wrong, and there is. But oftentimes the pain's a lot more worse than what the problem really is. There are 5 classic symptoms that I think everyone's aware of with inflammation, like redness or rubor and heat, swelling, pain or hypersensitivity, and loss of function. So under normal conditions, inflammation is an important protective mechanism. Of course, it's essential for healing, and it produces overt pain through direct activation of sensory neurons that conduct the pain signal. There are specific inflammatory mediators, bradykinin, serotonins, prostaglandins, cytokines, different cytokines, hydrogen ions. These are essentially released to the tissue, to the immune cells, and they can stimulate the nociceptors directly. So it's kind of like an indirect pathway for acute pain. They can also reduce the activation threshold of nociceptors so that the stimulation required to cause the activation is less. In other words, you can become more sensitive to pain. This is called primary sensitization. I won't get a lot into that today. So essentially with inflammation, you can see here the red, that's inflammation. You get release of inflammatory mediators, and it creates a whole process of activation of different mediators. You potentially can get sensitization in the area to make the area even more painful, and you start to get transcription of different mediators as well. And this is all occurring in and around the connection of the nociceptor to the spinal cord. Inflammatory pain is characterized by hypersensitivity, both at the site of damage and in the adjacent tissue area. So it's not just one small little area, it kind of spreads around. So when you go to treat it, you want to treat the whole fairly large area. And to be honest, that's why I like the BioFlex system really well, is because when you're treating inflammatory pain, you're using that sort of large array pad of lights, and you can treat a large area for inflammation as opposed to just very small specific areas with a laser, which comes in handy. And I'll talk about that shortly. One of the underlying mechanisms is the modulation of ion channels. And again, this is really complicated. One in particular is called TRPV1. This allows for huge influx of calcium calcium ions through the channel. Think of it as a little hole that opens and closes, right? And when it's open, it pours in calcium. The calcium changes the polarization of the pain nerve fiber and makes it more like sensitive, so you feel more pain. Light can actually have an impact on changing the diameter and the control of these of this gated pathway as well. So there are many potential ways that light therapy or laser therapy is going to be helpful for pain and treating acute pain. One is it can release endogenous opioids like endorphins. It can improve angiogenesis through increased growth factor secretion and collateral vessel into the injured region. For this, you're using lower dosages. There's a range, and that's typically what we're using in our standardized protocols. It can also help with producing localized anti-inflammatory effects. It modulates biochemical inflammatory markers and can produce local inflammatory effects in the localized cells and soft tissues. Another mechanism, which I'm going to talk about specifically, is it reduces the velocity of the nerve conduction action potential that produces analgesic effects. It actually blocks it by creating a synaptic kind of a vesicle that kind of blocks transmission of pain. It can also reduce mast cell numbers and degranulation, which I'll talk about shortly, and it can modulate ion channels like I just mentioned, like TRPV1. So mast cells, if you're not aware, mast cells are located in the vicinity of C fibers, so the C fiber pain fibers, and they have like a synapse-like connection with these fibers. And when you have more mast cells in the area, and if they start to degranulate and release what's inside of them, then it's associated with pain. It can actually irritate these C fibers and cause pain. Research has shown that photobiomodulation, that's what PBM or laser therapy, can significantly decrease the total number of mast cells and their degranulation, and thereby potentially decreasing pain transmission. This is just a reference to that article. Now, let's talk a little bit about how are you going to use lasers to promote analgesia. So this is to block nociceptive pain. This is like patients come in, like myself, I had sharp acute pain. I wanted some relief. I don't care about healing at that point. I just want some relief, right? So what you're going to do there is use much higher power density. Now, power density or radiance is referred to as milliwatts per centimeter squared. And the general consensus, if you look at the research, is they say 270 to 300 is kind of your minimum number to work with and greater. Okay, so you want to have a really high energy density and you want to have it over the area over a prolonged period of time, not just a few seconds, a little bit longer than that. And this is going to promote this really fascinating effect on blocking pain fibers and giving some analgesia to the patient. So I'm not talking about healing. I'm talking about blocking pain transmission and helping patients out of their pain. So it slows conduction velocity, reduces amplitude of the compound action potentials, and can suppress neurogenic inflammation. Some of this research has been done by Roberta Chow, where she showed, some of this work, and I'm going to show you what I'm talking about. So, and the references are below. So what happens is when you use this high amount of light, now it can be red or near infrared. And although red is maybe better for the superficial pain receptors because it concentrates there, but near infrared for the deeper areas of pain. These varicosities result from the inhibitive effect and result in the block of anterograde transport of ATP-rich mitochondria. So it actually blocks mitochondria that normally flow up and down an axon for it to function. So the interruption of fast axonal flow reduces the availability of ATP necessary for what's referred to as microtubule polymerization and maintenance of the resting potential. Again, you don't need to know the details in that. You just need to understand that it's blocking the path, the ability of mitochondria to make the nerve function because it's energy. The nerves need energy to function. In fact, nerve cells have the most number of mitochondria per any cell type in the human body and are most sensitive to light because that's the target oftentimes, right? So this effect for pain relief is in general completely reversible. It's not going to create analgesia forever. And they say, 24 to 40 hours. In my experience, yeah, you're not looking that long. You're looking at hours, maybe into 12 hours, maybe the day kind of scenario if you're doing it appropriately. I think 2 days might be a little on the generous side. This is what it looks like. On the left is an axon, right? This is a segment of an axon. This is, say a pain fiber. And then on the right, after 30 seconds of 830 nanometers continuous wave over the threshold of 300 milliwatts per centimeter squared, this is this vesicle that's forming and essentially blocking up the ability of mitochondria to flow. So this is what mitochondria look like when they're flowing along an axon. It's a normal, healthy axon that's transmitting the mitochondria for the nerve to function. So, there's been quite a bit of research now to look into this phenomenon. As I mentioned earlier, red light is really effective for this because it concentrates in the skin and superficial layers, and especially where a lot of nociceptors are. So it is really effective for that. But if you want to get deeper into, say, a joint injury, a muscle injury, where there's acute pain, you'll need to use near infrared as well. I would use both if possible. And if you're looking at where these pain fibers are, this is more work done by Roberta Chow, and she dyed the layers of the skin. You can see blue is epidermis, red is the basement membrane, and then you can see in the sort of purplish are the pain fibers and the nerves, and so into the epidermis. So the red light does a great job of getting into this specific area. Near infrared will go quite a bit deeper. So now, if you're looking at trying to induce nociceptive or analgesia of nociceptive pain, you want to make sure that you have at least 300 milliwatts per centimeter squared or higher. So for that, you need to understand a few things. You need to understand what the surface area is of the light coming out of your equipment, right? For our equipment, it's approximately 0.1 centimeters squared. That's actually why it's actually designed really well, is because it's a really, really small exit for the light to come out. So it's super concentrated as opposed to a much larger surface area. So when you see equipment that, like say class 4 that spreads it out over a large surface area, that's a much larger surface area that you're dealing with. Now it is pretty powerful and you do get good analgesic effects. But if you're trying to get a specific area, having all that light concentrated gives you a really high energy density, and it's that high energy density that is known to create this analgesic effect. So if you're looking at our equipment, the tip of it, I'm talking about this area here. Take a look next time. Of course, don't turn it on, and look, and you'll see a little glass plate, and then you'll see a small little sort of, it looks like a little diode or a little hole. That's where the light's coming out, and that's roughly 0.1 centimeters squared. It's actually kind of oval shaped, but the surface area is approximately that. So now we need to understand the power, right? So our LDI 200, that's the infrared. It's actually 180 milliwatts. It was rounded up to 200. Don't ask me why. I wasn't involved back in those days, but it's approximately 200, 180 milliwatts. At 100 this is about 1,800 milliwatts per centimeter squared. All right. So that's certainly meets a threshold of being able to provide analgesia. The LDR 100, which is red wavelength, this is approximately 80 milliwatts. I know it's 100, but it's rounded up. They took some liberty with that, but that's okay. And at 100%, that's roughly 800 milliwatts. So these definitely meet the thresholds. Even if you lower the percent power down to, whatever, like 50% is 900 milliwatts. 40% is, 700 milliwatts per centimeter squared for the LDI 200. So it's still quite powerful to do that. But what you're doing with this is not just holding it for a few seconds, you're holding it for much longer. So the idea here is that you're trying to induce analgesia, not necessarily treating anti-inflammatory and healing effects. I'm going to talk about that shortly. So you're going to target the most painful areas with the probe. You can set it to start off with at maybe 40% power. I personally go with the 100%. And you're going to hold it for 120 to 360 seconds in that range. You can try different times, right? And of course, it might depend on the depth of the target area as well. If I'm dealing with, say I was dealing with a deep erector spine, I assume in my back, I was holding it for at least three minutes in one spot. And as soon as I got up, the pain was eased significantly. And that was spasmodic pain. I'm just saying me, for example, but I've treated many people. So much longer, and you're trying to induce analgesia, not anti-inflammatory and not healing effects by this type of goal, right? Now, if you want to do photobiomodulation for healing and anti-inflammatory, which also is going to help with acute pain, then you're going to use a standardized protocols and a standardized length of time to use the probe, and that's much shorter. So you can first do the analgesia, and then you can later do the healing component. Even in the same day, I wouldn't necessarily do it back to back. You could do the analgesia first, and then hours later, you could do the anti-inflammatory healing effects, right? So remember that red light doesn't go very deep, roughly, I don't know, 40 to 50 millimeters, whereas near infrared, whoops, let me back up a bit there. Near infrared goes a little bit deeper, maybe up to 30, 40 millimeters, 3-4 centimeters, maybe even deeper, 5 centimeters. If you push the laser probe in, you can go even deeper, right? So you can access pretty deep areas. The deeper that the acute pain is, the longer you'll probably have to hold to get a good analgesic effect, okay? So just as a kind of visualization here, red light, you're targeting pain receptors at relatively superficially in the epidermis and dermis. Whereas near infrared light, you're targeting the pain receptors in the muscle and the, connective tissue deeper in the body. Okay, so I hope everyone understands that. If you're only using near infrared, yeah, sure, you're going to still affect the pain receptors superficially, but the concentration of light is still going down, right? Whereas red, it's all concentrated in that one area. So that's why it's actually a pretty good tool to have for helping create analgesia as well. So treating inflammation and really healing as well requires significantly less dosage than these analgesic effects. The goal with this type of treatment is really photobiomodulation. And here it's straightforward. You just use the standardized BioFlex protocols. This will help achieve the dosage to stay within the biphasic dose response. That is, you don't want too much, you don't want too little. There's a window, and that's the window for anti-inflammatory effects and healing effects, which will also help with pain, obviously, but it will help with the healing aspect. We also have an inflammatory protocol. If you're not aware of that, this is what it looks like. So if you have someone that's come in, they have really acute inflammation, you can actually use this protocol. There's 3 different levels or stages. The red light is usually continuous wave, but it can also be pulsed, and it's a relatively lower frequency, 10 to 40, and the duty cycle is 30 to 70, a little bit longer time frame, 8 minutes, as opposed to maybe 6 minutes or so. And then you can, go up the levels of stages. I find the stage 1 is usually pretty good. But if the inflammation is persisting after a week or so, you can start to go into stage 2. So the irradiance for about 100 milliwatts per centimeter squared, this can roughly reach targets using red light, roughly reach skin that's in that sort of area, right? If it's anything deeper, you're going to have to probably use near infrared. Okay, so I like using the combination, and that's kind of what we do, is using red and near infrared. Remember, some targets are readily available with red light. Like if you think about a finger joint or something that's relatively superficial, red light's going to do a great job of getting to all that tissue as well. But as you go into deeper and deeper, then you might have to consider, or you should be using near infrared as well. Okay, so hopefully everyone kind of understands the concept of using laser therapy and lasers for analgesia. Understanding, if you don't know what this surface area of your equipment is, say you have other equipment or whatever, your manufacturer should be able to tell you that. It's not really easy to measure. Most equipment is it's a much higher surface area than ours because it's spread out, or it's behind a glass plate, or whatever the case may be. But you should be able to find that out. Next webinar is on using our LED panel. I've had a lot of more in-depth questions about using the panel, so I'm going to delve into that a little bit more. And by the way, I'm going to do a webinar. I was listening to Andrew Huberman's podcast on light therapy, which was really good. But guess what? He got a lot of things wrong. So I'm going to do a webinar on what Andrew Huberman got right and wrong with respect to light therapy in one of his podcasts. So if you're a fan of Andrew Huberman, which I am, he's not an expert in photobiomodulation. It was pretty clear that some of his statements that he made were just inaccurate. So I'm going to clear up that with some references. So hopefully you can watch that one. This might be a pre-recorded one. I'm not sure, and then I'll post it. So if you're interested in it, keep looking at our website, or you just for your emails, because you should get a link to that over the next week or two. We'll also be out in Vancouver, April the 6th for Light Up Your Practice. If you're a practitioner or know someone out there that's interested in laser therapy in the Vancouver area, it's only $99 for the day. And you learn all about laser therapy, about our equipment, and a great lunch. And you're at the very top of the Blue Horizon Hotel that overlooks the Vancouver Bay area. So it's a great venue if you're in town and you want to come and join us. And if you need to contact me, my email is david@bioflexlaser.com. There's a few questions here. Okay. RE higher power levels for different situations. My system appears to only increase or decrease time of treatment. Is there any way to increase the intensity of the output? Well, Ed, I'm not really sure what equipment you're using. If you're using our consumer level or consumer grade levels, as I mentioned earlier, to get analgesia, you really can't do that without equipment. You need the laser for that, which is restricted to healthcare professionals, but you can still get a pretty potent pain relief through the anti-inflammatory effects by using it, as I've sort of mentioned in different webinars. For the nano, it's actually really high power. Mike, good question. I don't have it in front of me, but it's really high power, but it's not touching the skin. So you get a lot of reflectance off the skin as well. Again, it's not going to create an analgesic effect like a laser would, okay? Because it's spread out over too large of a surface area. But it is a pretty high power output, and that in part has to do with the fact that it's not touching the skin, and it's spreading it over a certain amount of area, and there's a certain amount of reflection that's going to be occurring with that. But it is quite helpful. Frequencies and power adjustable. So on the nano, frequencies aren't adjustable. What's adjustable is the different modes, which gives you full power, half power of the red and the near infrared. That's kind of how that works. I think on our website it talks about I did a webinar on the nano, and I talked about the power of the equipment. Why don't you use 1 watt laser head like those Omega laser? Oh yeah, that's great. You can use like 200 milliwatts kind of scenario. The problem with these, it's not a problem, but let me explain something. When you have a device that's like a shower head, they're held behind a glass plate. And sometimes they are, sometimes they aren't. It depends. If they're behind a glass plate, then you have the distance between the light that's coming out of the laser, then you have an airspace, then you have the glass plate, and then you have the target tissue. So it's not a direct contact to the tissue and you get spreading out of the light. I don't like that. If the shower has the diodes coming out where it touches the skin, that's great. The only problem with that is try treating smaller areas of the body with that. It's not really effective for that. If you want pinpoint accuracy, having a laser with 1 diode coming out is probably the best way to do it. But if you want to treat a larger area, a more efficient area with a shower head, that's also a great way to do it. But the thing with that is that if you want to treat, say, for anti-inflammatory effects, the downside of that is that you don't want tons of power. You want less power over larger surface areas to work with. And that's where having like ours have 240 LEDs. Now you think, oh, it's LED, but because there's so many of them over a large surface area, you actually get a pretty potent systemic anti-inflammatory effect, as opposed to just a shower head. You can achieve these things if you know what you're doing, no problem. It all depends on, if you want a hands-free, like for example, the Array is hands-free, that Omega is not. So you're stuck there doing that, and holding that for all your treatment, whereas ours is 90% hands-free. So there's advantages and disadvantages, and I hope that explains that. Doesn't the pod touch the skin though? Oh yeah, so it touches the skin, but the diodes, if you look at it, are spaced back from the point of touching. So when you adhere it onto the skin, there's an air gap. I don't know, it's like 5 millimeters or so between the LEDs and the skin. Yeah, I know. That was the nano reference. Okay, let me see if there's any other questions through the chat. Can you purchase the target with the mini port? You can purchase the Laser Pro for the mini port professional system, not the mini port home. And the reason for that is it's a restricted device. So you'd either have to be a healthcare professional or have it being used by a healthcare professional on you. And there's probably ways of getting around that. Let's see here. Oh, someone said I was brilliant. Awesome. Thanks, Sam. Ed, your salesperson may do a Zoom with you to show you how it works. Mine did. Okay, got it. Okay. Okay. So ischial bursitis, Ed. So right shoulder rotary cuff. Okay, so Ed, you can contact me directly, no issues. Let me see what you're doing, what's going on, and see if I can help. Sometimes it's not as easy as everyone has to understand. When you're dealing with a problem, whether it's bursitis or anything else, the bursitis is there because of a mechanical problem. That mechanical problem is not fixed, or it's been going on a long time. Good luck curing the problem, because you have to look at the whole body as a whole and treat all of that as well. So if you're not doing other things, that might be part of the process or the problem. And sometimes things are just challenging. So Ed, reach out to me and let me see if I can help you out for sure. I'm confused with the laser device to buy now nowadays, as there's so many laser and everyone have claims. Right. Okay. True. So here's the number one thing. If you look to buy anything, look to see if they're ISO certified as a medical device company. ISO 13485, 2000 and I think it's 16 or 18 now, medical device company. That's what we are. We're a class 3 medical device company, which is second highest tier of a medical device company. That means our equipment and our claims are all audited and regulated by Health Canada, the FDA, and everyone else. We've been around for 30 years. We're the original manufacturer of laser and light therapy devices in North America. Right? This is all we do, right? We don't buy stuff from China and just pawn it off and say we're experts. Look, there's hundreds of companies out there that just do that, and they all make claims. Most of them don't manufacture. Most of them just buy stuff and they use it as wellness devices, make no claims, and then they can actually say what they want, right? So you need to do your homework and don't listen to necessarily me. Read the research. I'm happy to share that research with you. Don't listen to a salesperson. Read the research. Try and understand what it is you're trying to do and accomplish. Andrew Huberman's a great example. Did he get everything right? No, he's not an expert in it. Why would he, right? He just gets some information, cursory and whatever, and he talks about it. He got a lot of things wrong, and it's in the literature. And I'm happy to share that with everyone out there so you can understand that even popular people out there might not necessarily get it all right. And I'm not saying I'm 100% right either. I just try and follow the research and give you what's out there that's been accepted by the research. Okay, can we use anti-inflammatory laser mode with IFC for pain relief? I mean, IFC is a great tool for temporary pain relief. It blocks the gate pain pathway, and it's great. It's just not going to help heal anything. The anti-inflammatory aspect of photobiomodulation is meant to resolve inflammation and help get it better. So that's really one of the key things that you're trying to do there. How about treating at the spinal level? Okay, so good point. That's chronic pain. If you're treating chronic pain, treat at the spinal level because you're looking at sensitization of the at that level. In acute pain, that hasn't happened yet, so just treat the localized area. All right, thanks so much for joining me today. Hopefully it was an insightful lecture. If not, let me know, and I'll do better next time. Till then, our next webinar, I'll see you then. Bye now.